And I have the pleasure to introduce the next speaker, Professor Mohamed Noamany, Monafe University, and he will be talking about INVECTUS trial. Dr. Mohamed.
Bismillah ar-Rahman ar-Rahim. Thanks for the chairboard, and many thanks for Professor Ashraf Rida and the IAVA board for the invitation. Okay. In my presentation, in the following few minutes, I will highlight one game changer trial, which is INVECTUS trial, addressing the role of rivaroxaban for rheumatic heart disease-associated atrial fibrillation. Background and rationale for this study: rheumatic heart disease affects over 40 million people, mainly in the low and middle income countries. About 20% of symptomatic rheumatic heart disease patients have atrial fibrillation. But unfortunately, in the past, no randomized clinical trials of anticoagulation in rheumatic heart disease-associated atrial fibrillation. Unfortunately, also, less than 1/3 of the patients are prescribed vitamin K antagonists, and just 1/3 achieve therapeutic INR due to different causes. So, an anticoagulant that does not need monitoring would be of a great benefit, like DOAC or the old terminology of NOAC. So, the objectives of INVECTUS trial compared to the direct oral anticoagulant rivaroxaban to vitamin K antagonist patients with echocardiography documented rheumatic heart disease, atrial fibrillation, and an elevated risk of stroke. The study design, it was an investigator-initiated international open-label randomized non-inferiority trial with blinded outcome assessment, designed and coordinated by Population Health Research Institute in Canada. Patients included in this study are those having rheumatic heart disease-based atrial fibrillation with either mitral stenosis with valve area less than or equal to squared centimeters, or patients having atrial fibrillation and Chad's VASC score more than or equal to. Patients were randomized equally 1-to-1 ratio into two arms, rivaroxaban 20 mg once daily, and it is subtitrated to 15 mg once daily if the patient having a creatinine clearance between 15 and 49 milliliter per minute. And the other arm, patients were randomized into vitamin K antagonist, keeping an INR in the follow-up visits between 2 and 3. Patients were followed up for approximately about 3.1 years. Outcome and analysis: the primary and main composite outcome is a composite of stroke and systemic embolization, myocardial infarction, death due to vascular or unknown cause. This is the original primary outcome. Primary safety outcome was International Society of Thrombosis and Homeostasis major bleeding, and 4,500 patients, 80% power for non-inferiority with margin of a hazard ratio 1.186. The study was conducted in 138 centers distributed in 24 countries across Africa, Asia, and Latin America, and there was an Egyptian contribution. The study have a unique balanced design where there is no gender or age difference. The percentage of patients having mitral stenosis did not differ between the two arms. Congestive heart failure, hypertension, diabetes, stroke, coronary artery disease, and Chad's VASC score between 0 and 1 did not differ significantly between the two arms. Unexpectedly and suddenly, the compliance to vitamin K antagonist was greater than rivaroxaban arm, and patients having INR level at the baseline between 2 and 3 was 33%, but with regular follow-up, the compliance and patient INR between 2 and 3 was 59% at the first year and approximately 56% between the second and the fourth year. The result of the study results, as we see, stroke, systemic embolization, myocardial infarction, or death, vascular or unknown, was lower in the vitamin K antagonist arm when compared to rivaroxaban arm. Proportional hazards assumption not met. The efficacy outcome, the intention to treat outcome, the primary composite endpoints, death and ischemic stroke, was significantly lower in the vitamin K antagonist arm when compared to the rivaroxaban arm. And the restricted mean standard time difference in the hazard ratio was significantly lower, as we see, for the vitamin K antagonist arm when compared to rivaroxaban arm. Regarding the safety outcome, no significant difference between the two arms as regard major bleeding, life-threatening bleeding, and intracranial bleeding, while fatal bleeding was significantly lower in the last column, as we see, for rivaroxaban arm when compared to vitamin K antagonist arm. So, restricted mean survival time for the primary outcome was significantly lower for vitamin K antagonist arm when compared to the rivaroxaban arm. This is the primary efficacy outcome. For the primary safety outcome, no significant difference between the two arms. Differences in this unanticipated, not explained by difference in the stroke. Vitamin K antagonists prevented 26 ischemic strokes versus 110 deaths. Difference in mortality driven entirely by heart failure and sudden death. No difference in bleeding. More frequent healthcare contact in the vitamin K antagonist arm for INR follow-up and control. Delayed effect apparent only after 3 years. So, the conclusion of the INVECTUS trial in rheumatic heart disease atrial fibrillation compared to rivaroxaban, vitamin K antagonists reduced ischemic stroke mortality without increasing the risk of major bleeding. So, vitamin K antagonists should remain the standard of care of rheumatic heart disease associated atrial fibrillation. Mortality benefit of vitamin K antagonists in rheumatic heart disease requires further study. So, to take the results of the INVECTUS trial in a nutshell, INVECTUS trial is the largest trial in patients with rheumatic heart disease, has found that in those with atrial fibrillation, vitamin K antagonists reduce cardiovascular events and mortality without increasing major bleeding compared to rivaroxaban. And the impact of this trial on the clinical practice, adjusted dose of vitamin K antagonists between 2 and 3 INR should remain the standard of care of patients with rheumatic heart disease and atrial fibrillation. And this is my last slide. And finally, thank you.
شكرا للدكتور محمد على الإليجنت توك وإنه قدر to deliver the message in the proper time. بشكر حضرتك وإحنا آسفين إن مفيش discussion. We will move to the next speaker.